Dr. Namrata is now ready, so we will start with the talk on achieving brilliance in trifocal outcomes with BLISS technology, OptiFlex Trio.
So thank you, Dr. Radhika. I would be talking about patient expectations from these premium surgeries, and especially the cases which we have done with OptiFlex Trio. Can we have attention, please? And yes, thank you. So there are no financial or proprietary disclosures, and patient expectation from premium surgeries that we should have good contrast, spectacle independence, minimum glare, and halos. And this should be there for near vision, intermediate vision, and far vision. And where and how to begin is we have to see the occupational lifestyle. Patient counseling is the key, and also the realistic expectations of the patients that are required. OptiFlex Trio lenses are trifocal, aspheric, hydrophobic, natural yellow lens with a BLISS technology. That means the brilliant light sensing system, which is a trifocal intraocular lens for presbyopia correction. And it is a single piece refractive 360 degrees square edge with aspheric optic with the intermediate addition of plus 1.85, near add of plus 3.5, optic size of 6 millimeter, and the overall size is 13 millimeter. It has an angulation of 0 degrees, and it ranges in diopter from 7 to 30 and in cylinder from 0 to 6 diopters. Then if we see the design, it has been designed for natural adaptation so that there's effective utilization of the unused light energy, optimum asymmetric and balanced light distribution at each focal point, and especially the optimized diffractive zones for intermediate and near vision without affecting the distance vision. There are 12 diffractive rings and there is minimal pupil dependency. So we see the light transmittance curve compared with a natural human lens. It is very much similar to that. And additionally, OptiFlex also blocks the harmful UV light and filters the violet and the blue light without losing the contrast sensitivity. The transmittance property is similar to the transmittance property of a young human crystalline lens for visible spectrum. Now, the optimum asymmetric and balanced light distribution is 45% for far, 27% for intermediate, and 28% for near distance, and it provides excellent vision at all distances. And the minimum loss of light is there, which yields 88.3% of the light for sharp and clear vision at various distances. If you look at the modulation transfer function, there's smooth transition between zones, which minimizes glare and halos. It is glistening free, and there's maximum light transmittance with uninterrupted functional vision. Now, this is the study that we did at RP Center in 100 eyes, and the pre-op, the post-op day 1, month 1, 3 months, 6 months, and 1 year follow-up details are available with us, and the endpoints were visual acuity, quality of vision, rate of PCO, retinal detachment, ease of fundus visualization, etc. Then the inclusion criteria, we took bilateral age-related senile cataract with grade of cataract permitting optical biometry, no ocular or systemic contraindication for surgery, and corneal astigmatism of less than 1 diopter. And the exclusion criteria was posterior segment pathology, media opacity other than cataract, corneal higher order aberrations more than 0.3, and patients with potential of intraoperative complications such as floppy iris syndrome and pseudoexfoliation syndrome, etc. So the target was that both eyes had to achieve emmetropia, and IOL Master Barrett's Universal 2 formula was followed, and we also did eye trace, aberrometry, and topography for these patients. So there is nothing much to the surgery because it is very simple, it is very easy to load these lenses, and it was loaded in a cartridge in which the viscoelastic was placed, and this is the OptiFlex Trio lens, which has got multiple rings, and this is then loaded onto the cartridge, and subsequently the cartridge was closed, and the cartridge that now the company gives is actually very good and very smooth, and there are hardly any problems with it. If you've made a 2.2 incision, you don't have to increase it because the cartridge goes very well with this, and the lens unfolds in a very controlled and a gentle manner inside the anterior chamber. Now, this is just to show the uncorrected visual acuity at 1 year follow-up, and 80 eyes completed this 1 year follow-up, and the uncorrected intermediate visual acuity also 80 eyes completed the follow-up with good intermediate vision as can be seen here. Now, if you see the near visual acuity, again, it was acceptable for all the patients, and most of the patients did become spectacle-free. The spherical equivalent is as shown and doesn't vary much in the post-operative period, and this is the 1-year spherical refractive outcome. 98% of the eyes had residual sphere in the range of 0 to 0.5 diopters at 1 year. And this is pre and post 1 year contrast, which also can be seen here. And this again is very much better as compared to the preoperative status. Now this is the eye trace, the high order aberrations, they improve in the post-operative period, and as per our analysis, they become better when we compare at 1 month and 1 year. This is yet another aberration profile which you can see pre and post 1 year eye trace. And this is the modulation transfer factor, which also is shown to be optimal at 1 year follow-up. So this is actually the supportive design which I was earlier talking about. The range, it provides 35 to 90 centimeter range of intermediate near vision and 38 centimeters of near focal point, 72 centimeters of intermediate focal point, and because of this, there's extended depth of focus for daily activities. Now, subjectively also we wanted to see whether the patient benefits or not, so the reading speed also becomes much better, and especially when you bilaterally implant the patients, then the effect is seen much more. And then when you do the subjective evaluation satisfaction for surgery, so the patients are fairly satisfied, 82% were very satisfied, and when you combine these two, almost all patients, 100% of the patients were satisfied. As far as the recognizing faces and reading newspaper is concerned, also showed a good correlation. Almost 94% of the patients were happy that they could read the newspaper or see the price tags and even walk on the uneven ground. To carry out any activity, again, the satisfaction index was almost to the tune of 100%. And of course, routine activity, 94% of the patients were able to carry out themselves, and 6% of the patients were fairly satisfied. So to conclude, Optiflex Trio gives excellent uncorrected visual acuity at all distances. More importantly, it gives 100% spectacle independence. There may be low incidence of glare and glare loss, and this is acceptable. Also, it reduces over a period of time. The contrast sensitivity and the optical quality are satisfactory. And at the end of 1 year, there is no posterior capsular opacification. So thank you very much for your kind attention.
Thank you so much, Namrata. That was a very wonderful study, and the results are very, very encouraging, almost seeming to match any other international product. Would Dr. Gaurav or Dr. Krishna Prasad Kudlu like to say any comments? And then I have 2 questions of my own.
Yeah, from evaluation till the usage, I use this product, madam, as we are talking about Make in India product. But if you compare with any other trifocals, what madam had showed on her presentation about the light distribution, but is almost 88.3, which is the highest. And the amount of glare and halos because of their technology is very good. And what we found out in our initial part of the trial only, their defocus curve is one of the, something like not sharp, it is more towards a smoother side. That might be the reason for lesser glare and halos. I think lens to see in the coming days, madam.
Excellent. Dr. Gaurav, any comments?
So I think my patients have been very satisfied especially the intermediate and near ranges are both looked after quite well, and the complaints of glare have gone down drastically with the current generation of lenses. It compares very well to any of the top branded ones, and even better as far as the patient satisfactions and outcomes go.
That's really nice. Namrata, 2 questions from me. First one is that I noticed that the lens is liquid. I mean, it's dispensed in a fluid, which is usually what we associate with hydrophilic lenses. So is there any reason why it is dispensed in a fluid rather than the dry form?
It is.
Can you put on the mic?
It is not a hydrophilic lens in that sense, because only the coating over there is hydrophilic, but essentially it doesn't have the hydrophilic properties. So that way I think it is safe. But because of the fact that it is on the outer side coated with a hydrophilic coating, that's why it's...
Okay, so it's a hydrophobic lens with all the benefits. The other question is, generally the push is that if you have a trifocal or a multifocal lens in one eye, then you encourage the patient to quickly have the other eye done. So in your experience of these 100 cases, did they all have the other eye done, or were they okay with maybe a monofocal in the other eye, or were they okay with their normal crystalline lens in the other eye?
We took patients who had bilateral immature senile cataract, and we did not take any patient in which the fellow eye had, or the patient had a pseudophakia in the fellow eye. So, so as a result, I think we will not be able to comment on that. But then most patients in our cohort, they got surgery in the fellow eye done fairly quickly, in the sense that there was a gap of not more than 2 months between the two eyes. I think once they also get one eye operated, they see better with that eye, and so relatively the other eye also looks, is kind of hazy. So that is why they are keen to get operated in the other eye also. Because in terms of contrast, it makes a lot of difference.
But it's good that they were able to go up to 2 months, like they didn't force you कि एक ही हफ्ते बाद
No,
करो,
not
so they were
that
able
way.
to tolerate
it was
that.
like 2
Yes, so that's a very important
2
thing.
weeks to 2 months.
Right, so that's good. Excellent.
I have a question. When the innermost zone is just 1 millimeter, and this is basically for the distance, so can it lead to some amount of more amount of glare and haloing?
So as would be expected that there would be more glare and halos, but their experience showed that it didn't. So maybe it is because of the transition. Dr.
Yes.
Namrata, I'd like to say.
So in our cohort of patients, we didn't find any glare or halos. They didn't complain of, and we didn't actually ask them also. We didn't ask this. I mean, we normally don't ask this question unless the patient complains, because otherwise, you know, the patient starts complaining. So otherwise, what we basically looked at was the subjective kind of a questionnaire, so that in his daily activities or her daily activities, the patient is, hampered or not.
And
So
one more question.
Actually, if you look at the construction of the lens, the optic, it has a refractive at the center. Then you have a diffractive zone, which is only 4 millimeters. So it's a combination of the refractive and diffractive. So if you have a lesser zone of the diffractive, the chances of having glare and halos are less. So that is why this lens actually, if you put this lens in the patients, they complain very least halos and dysphotopsia. The reason behind is because the central zone, which is working for the distance,